Assalamu alaikum jami'an, dear colleagues and friends. Good afternoon, good evening. On behalf of Global Health Development and the Eastern Mediterranean Public Health Network, I would like to welcome you all in this webinar, which is the first in a series of webinars that GHD EMPHNET will organize on a monthly basis. These webinars will approach and tackle different public health challenges facing the countries in the Eastern Mediterranean region, and will host distinguished experts from the region and the world. We all remember that on the last day of 2019, and while the whole world was celebrating the new year 2020, the first official report on an outbreak of a severe respiratory illness, later named as COVID-19, caused by a novel coronavirus, which is later also named as SARS-CoV-2, received by WHO from China. After that, WHO had declared it as a public health emergency of international concern, and later on as a pandemic on March 11th. Shortly after, the virus was
خالد اقول لك ارسل لي رقم حاتم ويداوم مع سلفه.
Hello, can people hear me? Over.
Yes, we do, Mark.
Good. I've had to come through on my phone because my laptop doesn't seem to want to connect. I apologize. Over.
Thank you, Mark. Thank you, Mark. Thank you so much. So after that, really, it was somewhat, in other countries, it is somewhat slower and giving these countries some time for preparedness. Many factors can be behind this variation. Some can be related to the degree of the government's preparedness and response, and others probably are compliance with the preventive measures. The response of countries to the pandemic was also varied. On one side, some countries choose to crush the curve through rigorous restriction of everyday activities. On the other hand, a few other countries had chosen not to impose that restrictive measures and keeping life activities as usual, which are a very small number, and many of them had regret that and come back to do the third option, which is adopted really by the majority of the countries through adoption of restrictive measures aiming at flattening of the curve. Now, while many countries have apparently started reporting a smaller number of cases on a daily basis, and the epi curve is flattening, meanwhile, the political, social, and economic status of many countries received debilitating consequences, which is why many countries began to put strategies and the plans in order to ease these restrictions and start what we call now as a new normal life. Today's webinars entitled Implementing Strategies for Easing of COVID-19 Restriction will address this topic with the three main objectives indeed: ensuring, number one, ensuring appropriate measures are satisfied when easing of COVID-19 restrictions. Secondly, adopting a flexible and informed approach for easing of COVID-19 restrictions. And we are going to hear two scenarios really from two countries, from Oman and from Morocco. We have four distinguished experts will be the panelists in this webinar. We have number one, Dr. Saif Al-Abri. He is the Director General of Disease Surveillance and Control, Ministry of Health, Oman. Dr. Mark Salter, Consultant in Global Health and Senior Medical Advisor in Public Health, England. And we have Dr. Mohammed Youbi, Director of the Directorate of Epidemiology in Ministry of Health, Morocco. And we have Dr. Wissam Mankoula. He is the lead of Emergency Operations Center of Africa Disease Control and Prevention. Welcome all dear guests.
Thank you.
In fact, each of our respected panelists is going to have a 10-minute presentation. And meanwhile, dear audience, you can send your comments, your clarification, your questions, and hopefully we will have the time to address all of them at the end of the full presentation. Now we will have Dr. Mark Salter, the first speaker, and Dr. Mark is a consultant for global health, communicable disease control, and senior medical advisor. Dr. Salter has over 40 years of experience of working on global health security issues. He currently works for Public Health England, establishing bilateral and multilateral links with partners, as well as strengthening public health capacities and capabilities and moving towards the establishment of Public Health Institute. Mark has extensive experience of public health system development, disease control, emergency planning, resilience and response, and CBRN, having worked during outbreaks and incidents. He worked in Central America, for example, in the area of dengue, hemorrhagic fever, measles, and cholera. In Africa, he worked on Lassa, SARS, Ebola viral disease, and post-conflict. And in Asia, also, he works on MERS, SARS, H5N1, and the flooding responses. In the last 5 years, he had worked across IMRO region to enhance capacities and capabilities to respond to CBRN events. Since the beginning of the COVID-19, he has been supporting the development and implementation of public health measures in England. Mark also has worked on elements of mass gathering medicine for more than 10 years and was one of the initiators of the first WHO Collaborating Center for Mass Gathering at Public Health England. Dr. Mark is going to present the implementing strategies for easing of COVID-19 restriction. Dr. Mark, please, the floor is yours.
Thank you, Dr. Lamy, for that lovely introduction, and good evening to all of you across the EMRO region. It's lovely to be engaging with so many colleagues under what are very difficult circumstances for all of us. I'm afraid I've had a few technical difficulties, and I'm sure we've all got used to webinars of one sort or another, but the system failed me. So if I could ask EMPHNET to put the slides up, which they received earlier on, that would help, because I'm unable to share the screen because I'm actually using a phone now. Is that possible?
Yes, we will do that in a minute.
Thank you very much indeed. So I will take the opportunity this afternoon in the short time I have to help us understand why the basics are important, why we need to know about the virus, why we need to know about the origins of the virus, how the virus is transmitted. And in understanding that, we can come under some understanding how we can control the virus and thereby actually allow our peoples in all of our countries to start developing what will be not a normal back to normal life, but a new normal life reflecting the issues of COVID-19 that it's created for all of us in the last few months. Could I have the next slide, please? So whilst I'll be talking, okay, we skip slide, that's fine. So what I just wanted to put into context is the fact that there's been lots of viral outbreaks which are respiratory over the last few years. Many of you are not old enough to remember all of them. I'm certainly not old enough to remember all of them, but we all remember very well SARS, the swine flu in 2009, and more importantly to many of you in the region, the MERS coronavirus that emerged in 2012. What we've seen with all of these viruses is that many of them have emerged and gone into abeyance. SARS, we haven't really seen since 2003. MERS coronavirus, we see circulating at very low levels. And obviously with the influenza viruses, we see them circulating on a recurrent basis, hence the need for vaccinations on a yearly basis with different formulations to reflect the changes in that virus on its yearly passage through the world. Can I have the next slide, please? So it's important to understand what the coronaviruses are and what they do. And in this little slide, it's just to demonstrate that we've got a phospholipid membrane with spikes on the surface, and it's through those mechanisms that the virus will attach. Obviously, that becomes important because in understanding how the virus infects people, what the mechanisms of infection are, we can consider how best we can deal with further transmission. Obviously, there's a lot of emphasis being put now on vaccination, which will significantly improve the capacities to go back to a more normal life. But equally, many countries are now exploring the opportunities of using immunoglobulin derived in individuals who have been infected as a means of actually mitigating, particularly those with severe infections. Next slide, please. The virus we know is transmitted and reintroduced on a number of bases. We believe that the virus as it emerged in a wet market in Wuhan in China, which wouldn't be dissimilar to the emergence we've seen of other viruses in the region, such as the SARS coronavirus back in 2002, 2003, which was again in the wet markets of southern China. But it's important to know the transmission, because what we don't want to do is to see further introduction of the virus from sources which we could readily curtail. And as we've seen in the last few days in Beijing, they now seem to have a significant number of individuals in a large market in Beijing, and consequently an increasing number of areas of Beijing's are being put back under lockdown. Next slide, please. It's clear, obviously, very shortly after the emergence of this virus last December, that the WHO were going to need to be involved in a significant level, and very quickly they declared a pandemic, a public health event of international concern, which obviously brings to the fore all the resources and the expertise that are possible. Next slide, please. Thank you very much indeed. The virus, as you can see now, is across the whole world. I don't think I need to actually go into any more detail on that. Next slide, please. And obviously, we're now in a major outbreak. Some countries are actually still on that upward slope, as we see in parts of South America, particularly in Brazil. We're also seeing increasing numbers in India. And in the last 24 hours, we've seen a significant increase in the number of cases occurring in Bangladesh. Next slide, please. And here, I'm sure you've all seen, this is the worldwide distribution. Apart from North Korea and one of the former Soviet republics on the Caspian Sea, there are no countries that have been unaffected. Some are proving to have been more effective in the mechanisms of controlling the virus. Others were less timely in putting their places in. And some countries have not had the mechanisms and capacities to deal in an effective way with the virus. Next slide, please. And here we see the distribution of the virus by week in the various regions, WHO regions of the world. The purple reflects the Eastern Mediterranean region, the yellow, the Americas, which we're still continuing to increase. And obviously we're also seeing the European case, which is the one I'm here to discuss mainly because of my understanding of that. We reached our peak some few weeks ago in the beginning of April. We are now seeing a decrease, but that is becoming less rapid now. And we are probably moving to some form of endemicity with the virus circulating in the population until such a time as we're able to get a vaccine to actually push it back to non-existence. Next slide, please. So these are some of the figures from the UK as of yesterday afternoon. Almost 300,000 cases. We're still seeing about 1,000 cases a day, but that's significantly down on our maximum in April when it was nearly 5,000 or 6,000 per day. 41,736 deaths. Again, we've seen a significant reduction in the number of deaths. The 38 reflects a weekend reporting, and the reporting at the weekends is usually slightly lower, but still a significant number. And this only reflects those primarily who've died when COVID is actually specifically recorded on the death certification. So I'm sure that when we look at this in the future and look at all the deaths over this period of time, we'll see that significantly more individuals have succumbed to COVID than those that are necessarily reported. Next slide, please. And this is important because one of the key things we've been talking about in the UK and we see in many regions is that there is a differentiation of the virus's grip on parts of countries, regions. Here you can see the regions in the United Kingdom, and you'll see that there's a variation in the number of cases and a variation in the rate of infectivity in the regions. Before we started relaxing some of our lockdown, we were looking at an R0, which was between about 0.4 and 0.6 after the peak of the epidemic. But what we're seeing now is the R0 increasing in some regions of the country rather than in other regions of the country. And we now have 1 or 2 regions in England which have R0s of 1. So there is a consideration being given at the political level to establish whether we need to think about regional variation, implementation of lockdown mechanisms to bring that virus and reduce that R0 in those specific regions. Next slide, please. And just for those of you, because I know we'll have lots of epidemiologists on board, these are our epidemic curves. The top one reflects the number of laboratory confirmed cases, cumulative and on a daily basis. And the lower 2 slides reflect those relating to death rates. And you'll see that we did reach our peak in early April, and we've had a steady decline, but it is only a steady decline. The deaths are beginning to level off, and we're anticipating we will continue to see deaths for probably several months, similarly with the occurrence of cases. This all needs to be taken into account when we're actually looking at easing measures. And as you will all be aware, with the incubation period of 4 days, we need to leave at least a gap of 2 weeks between implementing any relaxation of lockdown before we can ascertain the effects that that relaxation will have had. And what we're seeing now are some little blips, as I've said, where R naught is approaching or just going above 0 in some areas as the result of some of the lockdown measures we've had in place over the last couple of weeks. Next slide, please. So how do we go about actually bringing about individual mechanisms to reduce the lockdown? And that's by providing information. Next slide, please. Within the United Kingdom, key to our understanding is how is the virus circulating? Where is it circulating? Who's it circulating to? Who's becoming infected? So we have potentially, regrettably, very late, started a significant test and trace mechanism where all individual cases are followed up. As you might imagine, that's a significant endeavor. We have 23,000 contact tracers at various levels of skill sets, from highly trained communicable disease consultants through to health professionals, through to helplines to advise the contacts and the cases of what they need to do. Obviously, the contacts need to isolate for 14 days, and there will be a general risk assessment to ensure that those contacts truly have been in contact, because the danger of putting in lockdown and contact tracing, which is fundamental to controlling the disease, is that many of your significant services could be significantly affected. So for example, in the United Kingdom, we are having cases occurring in police where police have had significant contact with other colleagues, and consequently, sometimes very specific teams, or indeed some forces in the UK, have seen a significant reduction in the number of staff available to deliver their normal functions. So it's something we need to be incredibly careful about, developing how we identify who contacts are and who need to be put in isolation. Next slide, please. And these are some of the pieces of information we've developed. And I'm sure you'll recognize much of what's on here in terms of various forms of guidance, personal protective equipment, how do we track and trace coronavirus. And the reason why I've been very frugal with the amount I've done here is that you'll see throughout the slide set, there's a number of email connections if you wanted to follow up. Next slide, please. So the important thing is communicating this. What do you actually need to know? The population need to know an awful lot. And to take us on a journey from where we are now to where we are in the new post-COVID world, we need to make sure that all of the population, both healthcare professionals, politicians, and the general population, are aware of why we're doing what we're doing and why it's important for them to do it. Next slide, please. So we can ultimately stop spreading the infection. And we as health professionals can't do that alone. We have to have the population involved. That requires risk communication. Next slide, please. Washing hands, using tissues, avoiding touching your face. It seems very straightforward, but people find that incredibly difficult. And when we start talking about PPE, and in the UK, we've introduced wearing of face masks on public transport as of yesterday, and we are still seeing people putting on face masks, wearing gloves, but forgetting that these in their own right will transmit the virus. So they're still taking up the face touching behavior. They're not necessarily sneezing into anything apart from the inside of their mask. They take it off in an uncontrolled fashion and dispose of it in a way which could potentially provide a source of infection to others. And washing hands, people assume because they're wearing gloves that they don't need to wash their hands. We need to wash our hands when we take the gloves off, because not all gloves are totally resistant to the virus penetrating them. Next slide, please. And we have to try and convince people that there is a need to stay at home when they are unwell. It's easy, but when they are a contact, it's very difficult to make people understand that they need to stay at home for those 14 days to avoid infecting other people, even though in themselves they are perfectly well. Next slide, please. And I think we'll skip this one. Next slide, please. That's about our helplines. So we've got our stay-at-home guidance for households. It's just one important thing to try and encourage them to stay at home. Next slide, please. Next slide, please. And we've got guidance for businesses. We heard Dr. Lamy talk about, we now need to get to the stage where we balance the public health advice against the economic impacts. So in the UK, we currently have a 2-meter rule. You may be aware that there's lots of discussions about reducing it to 1. It is now a political decision, and we are awaiting the politicians to decide whether they are going to reduce it to 1 Obviously, if it's reduced to 1, then most of the hospitality, hotels, restaurants can open up. If they stay at 2, then it's likely that many of those will not be able to open up in the way they were, and we will see significant redundancies, which has a significant knock-on public health effect in terms of mental health, well-being, which has only really in the last month in the United Kingdom been taking center stage. Next slide, please. We've talked about face masks in the community. I won't talk about that anymore. Next slide, please. And the food business. Food businesses are very important. We have given them special status in terms of the track and trace. So if a case occurs in a food premises, then we would send health protection teams as opposed to ordinary health professionals, because we recognize the need to continue food production in the UK, as with anywhere else, is vitally important. Next slide, please. Next slide. I'm just going to go through these last few because I'm mindful at times. Cleaning in the non-care settings, vitally important, and we're not doing that as much as we could. Next slide, please. Next slide, cleaning and disinfection. Okay, and then I think the other important thing is the social distancing. So we've had real problems in trying to get people to understand this. And here, just as a pointer for you perhaps look at it, is the various guidance we've put down as to how we might socially distance. Next slide, please. And further investigation of the sort of areas we've been covering. Next slide, please. Next slide, please. I just want to quickly talk then in my last few minutes about how we're providing the evidence, because the evidence is what we are providing the politicians to make the decisions to ease lockdown. We have a scientific advisory group for emergencies in the UK called SAGE. It's made up of 50 or 60 individuals who are independent. They're not there representing government. They're not there representing PHE, although PHE does have 3 members. They are there to appraise the scientific evidence and provide options and recommendations to politicians who will ultimately make decisions. Next slide. We also have a new and emerging respiratory virus threats advisory group, which specialize in the respiratory side, who feed into the SAGE. And we also have a scientific pandemic influenza group on modeling that's been working very, very long hours to try and model all of the potential eventualities that releasing and removing lockdown measures might have, so that we can identify what key factors we need to monitor to ensure that lockdown release is actually working, and we're still seeing a decrease in the number of cases and deaths. Next slide, please. And I'm going to finish on this slide because I think the vitally important thing is that any changes have to be based on the evidence. However, there becomes significant political ramifications if they are followed to the letter. So it's for politicians working with our scientific advisory group for emergencies to determine exactly where there is latitude to release some of the lockdown issues and where we need to keep specific lockdown issues in place for a significant time into the future, whether that's until we get a vaccine or whether that's until we get to the stage where there are sufficiently few numbers that we can have a high degree of certainty that all cases and all contacts will be identified and followed up. And on that, I'll finish because I appreciate that others need to come after me. There's so much more I could say, but thank you for your attention.
Thank you so much, Dr. Mark. Thank you so much for very comprehensive, and you highlight a lot of issues regarding the COVID situation in UK, and there are a lot of issues I'm sure the audience will consider probably later on we are going to address. The next speaker will be Dr. Wissam. Wissam Mankola. Dr. Wissam, he's from Africa CDC, and although it is a young institution inside in Africa, but honestly they are doing great job for public health in Africa. And the guidelines that they develop regarding the easing of restriction is really very nice, and I like it so much. Straightforward and very pinpoints, very clear. Dr. Wissam, he is a healthcare professional with over 11 years experience in public health emergency management, epidemiology, and practicing medicine. He worked for governmental, non-governmental, and international organizations, On 2016, he was selected as one of 10 African public health professionals to support establishment and operationalization of Africa CDC under African Union. He is currently served as the head of Africa CDC Emergency Operations Center. He has established a coalition in collaboration with WHO and US CDC to push the agenda of public health emergency operations center in Africa and support member states. He led Africa CDC missions to respond to various outbreaks in the continent, such as Ebola in DRC 2019, Rift Valley fever in Kenya, and cholera in Zimbabwe 2018, and currently in Africa CDC incident manager for COVID-19 in Africa. Dr. Wissam, he is going to cover Africa CDC guidance on easing lockdown. Dr. Wissam, the floor is yours, please.
Thank you, Dr. Faris, for this nice introduction, and I'm really happy to represent Africa CDC and to be with EMPHNET and this first webinar about easing the lockdown. So in my today presentation, I'll cover Africa CDC guidance for easing the lockdown. And under this section, I'll cover background about the situation in Africa and the challenges for implementing public health and social measures, impact of sustained public health and social measures, and some consideration we need to take in mind before easing the lockdown, and finally the steps for easing the lockdown. Then I'll give overview about how Africa CDC formulate a structure to support member states in terms of preparedness and response for COVID-19. So globally, as of this morning, we have more than 7.7 million confirmed cases of COVID-19 reported globally, and with more than 430,000 deaths. This has been reported in more than 200 countries and territories. In Africa, so far, we have more than 250,000 cases, confirmed cases of COVID-19 reported, with more than 6,700 confirmed death, and with more than 100,014 recoveries reported in the continent. For the last 1 week, between 8th and 14th of June, we have 20% increase in number of cases in comparable to the previous week. And there is significant increase in number of cases on all 5 regions of Africa. North Africa, Southern Africa, Western, Eastern, and Central Africa. And Southern, 29% increase in comparable to the previous week. So since the beginning of the outbreak in China and following the Chinese experience and also the experience from Europe, lockdown measures and public health social measures are considered key components for controlling this COVID-19 pandemic. This is why one of our guidance, stepwise guidance for Africa CDC, we recommend different intervention, and one of these intervention focus on social distancing measures, including lockdown. But with a long time with this pandemic and fighting this pandemic through different prevention and control measures, so countries start going for easing the lockdown. So it becomes very important for Africa CDC to develop this guidance for member states to facilitate moving from lockdown to start easing the lockdown in a safe way to prevent a rapid increase in number of cases after easing the lockdown. So public health social measures is composed of community physical distancing measures and also individual physical distancing measures. For community physical distancing measures, it's focused mainly on movement restriction for the communities and also shielding medically vulnerable groups. It's include staying at home order, closure of schools and businesses. Maybe you can have a partial lockdown in some of area, put them under quarantine, or national lockdown. Also it include travel restriction as well. For individual physical distancing measure, this include use of non-contact greetings and also keeping distance from the people that you are dealing with, in addition to hand and respiratory hygiene, using face mask in public settings, and also isolation of cases and quarantine of contacts. So what is the status of these mitigation measures in the continent? So in terms of travel restriction, we have currently 43 countries under full border closure, 7 countries under international and air traffic closure, 2 countries imposing travel restriction to and from specific countries, and 2 countries they have entry and exit restriction. And most of the countries they are imposing mandatory quarantine for the people arriving to these countries. And as a summary for the mitigation measure in member states in Africa, so far we have 38 countries are imposing closure for educational institutions countrywide, and 54 countries are imposing limiting public health, public gathering. Then 20 countries with limit on prison and hospital visits. 18 countries start implementing mass screening and testing. 41 countries advising public use of face masks and clothes. Regarding lockdown and nighttime curfews, 35 countries under nighttime curfews, 21 countries partial lockdown, 16 countries national lockdown, and 28 countries start easing and mitigation measure, easing the lockdown. So how this social measure, public health social measures are important for the member state during the implementing these measures. So we have noticed that these measures give room to the countries to ensure better preparedness at the early stage of this outbreak. And we manage as Africa CDC to support countries through distributing more than 2.8 million tests. Currently, the continent conducting so far 3.4 million tests for coronavirus. And also we managed to distribute more than 9 million masks in the continent. This is in addition to different infection prevention control supplies and also lab test kits and lab supplies. In addition to deployment of human resources to support member states for response. So these social distancing measures give rooms for us as Africa CC as well as member state to ensure preparedness to face COVID-19. On the other hand, there are some drawbacks for these social distancing measures. And this is not only touching the economy, but also social and mental health and medical and public health sectors. For example, some of the drawbacks for these social distancing measures on medical and public health sectors include reduced access and attendance for non-COVID-19 conditions. Also, it limits the ability of healthcare system to conduct vaccination campaigns, also access of the people for antenatal cares and delivery. For social and mental health impact, we have noticed that there is increase in domestic and gender-based violence. There are some mental health disorder increase under these social and distancing measures. For the economy, also it increased the pre-existing wealth disparities between the people, and it is expected that 40 to 50% increase in Africa in extreme poverty rate. So before countries start thinking of easing the lockdown, so there are 3 main questions WHO recommend that countries need to take in consideration before moving from lockdown to easing the lockdown. The first question is the epidemic control. And there are some indicators to make sure that the epidemic control within the countries. First, you need to notice that there is a continuous decline in the number of cases, at least for the last 3 weeks, and also a decrease in positivity testing for COVID-19 in the countries, at least for the previous 2 weeks, in addition to continuous decrease in the number of deaths reported due to COVID-19 for the previous 3 weeks. In addition to the first question is epidemic control, the second one is the healthcare system able to cope with the expected increase in number of cases after easing the lockdown. And the third important question about public health measures in place. Is this public health measure able to detect cases, able to conduct needed tests for detecting these cases, isolate these cases once they are identified, and also conduct the needed contact tracing. So these three questions are key, and the countries need to do careful risk assessment before moving from lockdown to easing the lockdown. And this should be done on a gradual phase. When the country, after they're done with the risk assessment and now they decided to move to easing the lockdown, this should be done on gradual phase. Starting from a local restriction to regional restriction, start moving this restriction till you reach to national restriction. And we are recommending 3 phases to move from complete lockdown to easing the lockdown completely in the 3 phases. And between each one of these phases, we should keep at least 2 weeks gap to assess how the epidemics is going within the countries. If there is increase in the number of cases, is increase in number of deaths after start easing the lockdown measures, or we are keeping stable number of cases and also keep lowering down the number of cases and number of deaths in the countries. So the 3 main steps, the first one, it's focused on gradual easing for public health and social measures. And during this phase, the target is the essential service to minimize the risk of transmission during this phase. So we start easing the social measure on essential service. And in the coming slides, we'll give some example what kind of these essential measures, including the travel, including the economy, including different public health measures. The second phase, as I mentioned, we need to keep at least 2 weeks between each one of these steps. The second step, we need to do again reassessment using the 3 questions that we raised in the previous slide. But if the epidemic controlled, if the healthcare system able to control the expected increase in number of cases, and also public health measures in place. After doing this assessment, we can move to the second step. Once we are done with the second step, we do again another phase of assessment. If there is no rapid increase in number of cases and we continue controlling the outbreak, at this point of time, we can go for the third step, which we arrive to the new normal phase, returning to the normal, but this is a new normal under COVID-19. It's important during all steps, all the member states need to maintain focus on protecting the vulnerable groups, and also suspected cases must be rapidly detected and tested. Case should be isolated. Physical distancing, hand respiratory hygiene measures must be maintained at all steps. Work from home should be continuous whenever it is possible for whatever businesses. Non-medical mask, we should also wear this non-medical mask for public whenever it is impossible to keep physical distancing. And so also adequate training, adequate treatment should be available to minimize the number of deaths. Transparent and clear, timely communication with citizens should be in place as well. We, at all stages, we should keep this non-contact greetings, hand and respiratory hygiene, maintain at least 1 meter distance from the people, and remain at home whenever you ill. This is recommendation should be there at all steps. This is the details of the steps for easing the lockdown. Slide will be available for you to see what kind of recommendation we are giving to the member state at each step. For example, at the first step, if we talk, for example, the travel, moving from travel restrictions. So we're recommending at the first step to start with internal travels, international travel to be only when necessary. If we move to the second step, we can start international travel with some entry screening and also maybe entry quarantine in place. When we go for the third step, we have free trade and travel moving. The same, we have different recommendations according to each step for communities and for healthcare and for economies as well. How Africa CDC, this is the last part of my presentation, how Africa CDC is helping the member states. So early at the beginning of this outbreak, Africa CDC called for emergency ministerial meeting. In this emergency ministerial meeting, Health Minister adopted Africa Joint Continental Strategies to ensure preparedness and response for COVID-19 in Africa, and also endorsed AFTCOR Task Force, Africa Task Force for COVID-19, as a continental structure for coordination, collaboration, and communication between member states and fast track the preparedness and response effort to COVID-19. At the top of this structure, we have African Union Bureau of Heads of States, where we have 5 presidents, 1 represent each region, in addition to African Union Chairperson and the Africa CDC Director. This is to give strategic guidance for all African Union Commission regarding the response for COVID-19. Under this presidential committee, we have 3 ministerial committees, one of them for Health Minister, another one for Transport, third one for Finance. Then we have AFTCOR Task Force to have a steering committee. Under this steering committee, we have 7 technical working groups, which give technical guidance for Africa CDC about the response to this outbreak, including surveillance, clinical care management, infection prevention control. This is in addition to regional economic committees, 5 regional economic committees as well involved in the response. This is to give strategic guidance for Africa CDC and also facilitate the communication with member states. Then the implementing part is Africa CDC ENSA management system. We have the ENSA manager, we have liaison officer for communicating with different partners and member states. We have safety and security officer to ensure the safety and security of the team and the responders of Africa CDC, and also communication team. Then we have operation section. Under operation section, we have 4 main units. One of them focus on surveillance, another one laboratories, preparedness and countermeasure, and rapid response team. Then we have planning section and finance and admin. This is the implementing part of Africa CDC. And this is the one responsible for communicating with member states, raising the awareness of member states regarding different guidelines that Africa CDC is producing, and also supporting member states, not only regarding the COVID-19 and easing lockdown measures, but also to support the response capacity of the member state on all these areas. Finally, the key message, lockdown has provided member state with the time to prepare healthcare system to respond to this outbreak. But on the other hand, lockdown also had a negative impact on medical, public health sector, social and mental health, and the economy. Before easing lockdown, member states need to take in consideration 3 main issues: if the epidemic is controlled, healthcare system able to cope with the expected resurgence of number of cases, and also public health measures are in place. And member states should begin easing the lockdown on a stepwise approach. This is very important to avoid the unnecessary increase in number of cases. Thank you so much, and happy to be with you today.
Thank you so much, Dr. Wissam. Very comprehensive overview of the situation in Africa and very practical steps on easing the restrictions. And after having these 2 presentations from Europe and Africa, we are going to have the experience of 2 countries from the region. We are going to have Oman and Morocco. And we will start with Dr. Saif Al-Abri. He's the consultant in infectious disease and Director General of Disease Surveillance and Control in Ministry of Health in Oman. After his graduation, Dr. Al-Abri, he did his training in infectious disease at the Royal Liverpool University Hospital and Liverpool School of Tropical Medicine, and he is awarded the FRCP in 2008. He worked for a long time in the Royal Hospital in Oman, starting from a consultant in infectious disease, then the head of the Department of Infectious Disease, then the head of the Department of Medicine, and then a Deputy Director General for the Royal Hospital. Dr. Al-Abri also is an international advisor for the Royal College of Physicians of London, and he is an associate editor of reputable journals like the Journal of Infection and Public Health and the Annals of Clinical Microbiology and Antimicrobials. The title of his presentation, I am sure you can see on the slide here, Oman Experience with Easing COVID-19 Restriction. Dr. Al-Abri, the floor is yours, please. Unmute Dr. Al-Abri, please. Unmute. Yeah, thank you.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. And it gives me a great pleasure to talk to you today about Oman's experience with regard to the easing up the restrictions from the lockdowns and from the restrictions for the COVID-19. And I'm going to start my slide with this slide, which says, I'm sorry, it's in Arabic, but it says Oman towards recovery. And I'm going to say in my last slide, why is this? So each day we produce a report to the higher authorities about the situation in Oman. And so far, like day before yesterday, which means yesterday's results, we had around 1,043 new cases. We roughly diagnose between 700 to 1,400 a day cases every day. We have now up to date around 25,000 cases with a recovery of around 11,000. Until yesterday, we had 109 deaths. We also check every day the numbers of the ICU patients. So yesterday we had around 104 patients in the ICUs and more than 300 admitted patients with COVID. And we also produce our EBI curve on daily basis, which is sustained right now. We are sort of in a flat curve. And our death rate is around 0.4% out of all the diagnosed cases. The interesting thing is that the majority of our patients are from non-Omanis. I'll show you later on that around 40% of the population, or 41% are non-Omanis. Also, the majority are males, and this reflects the non-Omani population because almost 90% of the non-Omanis are males. And also it's in the young age group between 15 to 50. We have 11 governorates, and we do show the numbers in each governorate. And as Mark has mentioned, that the prevalence of the disease is really different between different governorates. And most of the cases within the Sultanate have originated mainly from the capital, from Muscat, and it's people who are really moving around from Muscat to other parts of the country are spreading the disease. And you will see in this column the different governorates and the proportion of the Omanis and non-Omanis. And you can see, for example, in Muscat, most of the people are non-Omanis. When we go to the other governorates, the majority are Omanis. Apart, for example, from Al-Wusta, for example, here, where we have 850 non-Omanis, basically because the Omanis there, Al-Wusta, which is this part where we have, until yesterday, we have around 908 cases. This is almost 1/3 of the geographical area of the Sultanate, but the local population there are maybe around 20,000. But the expat populations, because this is now an industrial area, are more than 25,000. So most of the cases here, these 850, by today it's almost 1,000. This is an outbreak in an industrial area. The rest of the country is almost the same. And this is our classification of the cases where it started that it's travel related. And then we have clusters where we can really pinpoint that these are clusters from somewhere. But then now you can see recently, it's more of a community transmission. It's very difficult to find out the source of the infection for a specific person. From before, over now, the last 6 years, we were trying to work on public health emergencies. And so in 2017, we came up with our all-hazard public health emergency preparedness and response plan. And at the beginning of the COVID outbreak, we came up with the COVID preparedness and response plan, which is a reflection from our generic plan. So it was, we tried not to invent the wheel, but to build on what we have done before. And so the National Emergency Preparedness Plan was built on governmental leadership, or all of the government approach. We also have the public health response. So our plan from before, and this is helping us a lot now with easing up the restrictions or in the recovery phase, testing, isolation, contact tracing, national surveillance system for all health institutions, whether they are government or private, and it's all electronic, health promotion and risk communication, ports of entry, healthcare system, where we have concentrated in the surge capacity, infection prevention and control, keeping essential services, and reopening of other health services. And we had, His Majesty the Sultan has formed a National Supreme Committee to deal with the COVID-19 pandemic. He has chaired himself 2 of the committees. This is one of the first meetings that he has chaired. And the committee is represented by many stakeholders, including the commander of the police and the commander of the army. So these are the main things, main pillars were what we have built on our preparedness and response plan. Leadership, as I mentioned, Supreme Committee. There's a technical committee, which is chaired by the Minister of Health, which looks at the technical issues, activation of medical response and public health sector emergency. We had an incident command chain for public health across the whole country. Surveillance, we have established electronic surveillance system, which is web-based and also through an application. So all our surveillance is electronic and it's immediate. Involvement of both the public and private sector. We are participating in the INFLU, and we are going to conduct a national sero survey in the coming 2 weeks, which we'll do it in 4 stages, 3 weeks apart. So we are planning to do a sero survey for around 20,000 population. Communication, there's a weekly press conference by the Supreme Committee, formation of a national media cell, and it's chaired by the Undersecretary of Media. Risk communication and mobilization, we have a 24/7 call center for the Ministry of Health. Expertise, we have guidelines, as the other speakers have spoken about. Research, we are conducting research. The National Research Council have supported many research projects, and they have funded them well. We are also taking part of some of the WHO clinical management trials. Preparedness, I've already mentioned about many of them. Logistics, that was of a concern to us from the beginning, so procurement of all medical supplies, innovation and local production of PPEs and ventilators in partnership with academic institutions and private sector within the country. This is just to show you our, Mark Salter at the beginning has spoken about the RO or R0, and our RO has gone up to almost 3, in fact, up to the confidence interval. If we look at the confidence interval, up to 4.6. And then at this stage, we have implemented the public health control measures, like suspension of schools, boards of entries, sports activities, mosques, public gatherings, all stores, restaurants and shopping malls. We have reduced the numbers of employees in workplaces to around 30% or less. And then after the middle of April, we have induced a lockdown because our RO came down near to 1, but then it started to go up. And here we have introduced the lockdown between different governorates and even in specific areas. So in Muscat, we have 2 areas of lockdowns, and that was associated with a local transmission or a big outbreak in one district, and that has been locked down. And even Muscat itself as a governorate was under lockdown. And then started to continued, but then we started to see that the RO has started to go up. And this was mainly because of Ramadan and the Eid, because in Ramadan there were a lot of family gatherings, and during Eid people also started to gather together. And because this has taken long, there was some sort of apathy within the community. And people really, because there's a lockdown until now, all our malls are closed. Many of the activities are still not started. we started to see that people started having weddings not announced. So we are still seeing increase in the numbers, although the RO is around 2 right now. So we started to ease up some of the restrictions. So now the lockdown is not anymore since the 22nd of May. We started also to open up some businesses, and now we are running them in bundles, and I'll come to the details. So out of the Supreme Committee, 2 subcommittees have been formed. One is to look at the finances. The other one was to look at the recovery plan. So a recovery task force out of the Supreme Committee has been formed and is chaired by one of the ministers, working across all different sectors. And the main aim is really to establish governance as well, along with the easing up things. Governance is part of it. So this is what's called Oman Towards Recovery, and this is the document that has been produced. And the objectives of the plan, which we have written initially, we have written the first draft, that public health is the basis and the priority for a recovery plan, creating a systematic institutional mechanisms for recovery plan. So although we started to ease up activities, we have produced guidelines and we have made commitments from different stakeholders, and this has been approved by the Supreme Committee. We have divided we have 8 sectors. For example, the aviation sector, the general transportation sector, the health sector, the education sector, the commerce and industrial sector, the tourism sector. And we have met with all these sectors, and we went through the plans and the preventive measures that they need to establish. And then we want to give them the ownership of it. So we give them the technical support, but we want them to take the ownership of running them. So the main aim is to continue applying the preventive and infection control measures all over the place, and also protecting the high-risk groups. So the criteria that continuous epidemiological surveillance by using more effective methods such as use of artificial intelligence to activate monitoring and follow-up programs. And we are now, we have a lot of initiatives for IT and artificial intelligence, expanding the scope of our lab, and we are building up our lab capacities. Sufficient public health capacity is in place, framing the precautions to be followed legally, and workplace preventive measures. So there are different documents which have been produced. So the main document, which is the recovery plan, we have then another one, which is going back to work is a step towards hope. And this really discusses what's to be done. What are the responsibilities of the workplace? What are the responsibilities of the employees themselves? And what are the general rules for them? Also, for example, we worked with the Minister of Tourism to produce guidance for hotels and tourism sector. And now we're working with almost all of the sectors to establish these guidelines. I wanted to share this because it's easy to talk in theory, and it's easy to go back to the literature. We get asked a lot. Don't you learn from the experience of Taiwan? Don't you learn from the experience of Greece? Don't you learn the experience of New Zealand? But I think we need to look at countries at their own context. So, for example, in Oman, we are around 4.6 million inhabitants, but 41% of them are non-Omanis. The majority of these non-Omanis are non-educated. They are really more of freelancers. They don't speak Arabic or English. It's very difficult to reach them. And when you see, they are mainly males and they are in the productive age group. And these people came to the country to live, and they need to live. So if we lock down, for example, now it's 3 months, we need to look after these people. and they need to have the support. So we started easing up according to what we have said before, and according to what Dr. Wissam has mentioned about those principles for locking down. So now we are working, and we started to work on a strategic plan for the coming 6 months. Now we have almost completed 5 months. We went through an experience. At the beginning, it was much of the unknown. It was sailing through darkness, but now we know a lot. So now we want to rethink about what we are doing. Should we keep doing what we are doing? Should we change the way we do things? Can we get use of the technology? What more things that we can do? We are doing things through universal health coverage. We want to reach to every single person in the country. There was a royal decree that everyone who is in Oman is entitled for free medical service, whether he is Omani or non-Omani, balanced and flexible recovery plan. So for example, the Supreme Committee met last week, 9th of June, and they took some measures. One of the measures they took, that they have ordered that we started to have a lockdown of certain areas. I think there are 5 of them. I can't see the whole. So there were 5 of them. These are the tourist areas now in summer, and many people will go there for gathering. So these have been locked down so that we, for example, the far south called the Far, they didn't have cases of COVID-19. They had few cases, but mainly from truck drivers going there. So now it has been locked down because right now there's the monsoon, and it's like you are in Europe. It's full of green and mist and rain, and the population there is around 100,000. But during summer, from mid of June to mid of September, around 1 million people go there. From Oman, even there are European charters which goes there. And also,
Dr. Saifi, please, but just to consider the time.
I'm finishing. This is my last slide. But at the same time, we have opened new businesses. So although we are locking down, we are opening new businesses. I said at the beginning that Oman towards recovery, last week or the week before, His Majesty chaired the Supreme Committee, and he said now we have to live with COVID, and we have to do whatever it takes to live with COVID, putting in mind the preventive measures. And that's, as what Mark Sauter has said now, the COVID is considered to be an endemic disease or part of the endemic diseases. And I'm going to stop here. This was my last slide. Thank you very much.
Thank you so much, Dr. Saif. Really very impressive experience from Oman. So it is inspiring to many countries indeed. And the last speaker will be our colleague, Dr. Mohammed Yubi. And he's the director of the Directorate of Epidemiology and Disease Control in the Ministry of Health in Morocco. And Dr. Yubi, he's awarded doctorate in medicine from the Faculty of Medicine and Pharmacy in Rabat in 1991. And then his national qualification in preventive medicine, public health and hygiene, 2012, and master in epidemiology. And he's one of the graduates of the first cohort of Morocco FETP. And Dr. Yubi worked as a head of division of communicable disease, then deputy director of the National Institute of Hygiene, then chief of the epidemiological surveillance service in Ministry of Health. Dr. Mohammed, the floor is yours, but please consider the time. Thank you.
Thank you, Dr. Faris, for this presentation. And I would like to present my sincere congratulations to Global Health Development for organizing this successful webinar. And my special thanks to Dr. Mohanad and Dr. Mohsni for inviting me. I articulated my presentation as follows, keeping in mind to answer to three main questions of this webinar. When countries could loosen COVID-19 restrictions? 2, what is the phased approach in loosen process? And 3, what are the main prerequisites, criteria, and precaution for that? But allow me to present briefly the national COVID-19 surveillance and preparedness plan, which aimed to achieve three main objectives. 1, prevent spread of the virus. 2, reduce the risk of mortality. And 3, avoid health system overflowing. The pillar of this plan, the principal pillars are to the early case detection, second, case management, and infection prevention control to prevent spread of the virus from for health departments, and contact tracing, and the pillar of the very important pillar of communication. We don't describe the epidemic curve, but we will focus on the fact that Morocco has chosen the option of flattening the curve, adopting lockdown strategy. As you can see, 1 week following the first Moroccan imported case on 2nd March, the flights between Morocco and Italy have been suspended, and 1 week later, implementation of first distancing measures and suspension of all international flights, and the state of health emergency was decreed on March 20 for 1 month and would be extended twice. Wearing mask had been made compulsory on April 7th. And as you can see also, there is a special national COVID-19 fund established at the government level, and the Ministry of Health is the principal benefit of this fund. And since 11 June, this is a progressive strategy of lifting of containment. The containment is decided to lift the containment following the rationale as follows. This it was noted significant slowdown of SARS-CoV-2 spread based on the rate of reproduction, a significant COVID-19 case and death decrease, and the unsaturation of the national health system. So Morocco, we can say that Morocco has reduced the spread of the epidemic and its consequences. But maintaining containment for a long period is not a realistic option. This is, of course, economic and social impact, and also impact on another morbidities and health problems. The key epidemiological indicators at the same date of the beginning of lifting confinement strategy are, as you see, confirmed cases were more than 8,000, and most part of those cases are recovered. Percentage with the proportion is 88%, and the date we enregistered 2012 case of death, and the rate is 2.5, and it's still in Morocco some 700 or between 700 and 800 active cases. There is another argument, is that case in recent weeks became almost exclusively asymptomatic. So it's related to this national strategy of screening. It's for that our last cases are almost exclusively asymptomatic. So also only infection SARS-CoV-2 infection are not veritable disease cases. So we can see that we can say that containment strategy allowed to Morocco to avoid many thousands of cases and thousands of deaths and intensive care case. However, there are several uncertainties linked to lack of knowledge both on the virus and on the disease. For example, questions on viral transmissibility, on immunity duration, on the prevalence of asymptomatic forms, and also on informations about on effectiveness of public compliance with the containment measures. So the risk remains the resurgence of the epidemic after containment lifting. This risk remains possible. Principle of containment lifting strategy in Morocco are to have a certain prerequisites and to have a gradual process, gradual on the geographical consideration, and measures easing implementation. And we also keep the principle of reversibility, because we can return back to previous measures if situation of epidemiological situation become severe. So we have two kinds of criteria to follow this. We have epidemiological criteria and the criteria linked to care offer. So we have monitor and projection of case under several scenarios. For example, scenario according abrupt lifting is projecting cases as you see. Very important number effective of case at by the end of July, and the scenario of lifting according the principle give us the follow this this curve. As you can see, only 3,000 cases by the end of July, the beginning of August. And also very other important arguments, because as you can see, different regions of Morocco, I would like it's to note that this is the true map of Morocco, is not the map shown in the previous presentation. Morocco is 12 regions, and the plan is implemented in the 12 regions. Also data, we have data from the 12 regions. So you can see that regions are not affected in the same way. It's for that one of principle is to have this graduation on geographical based. So the lockdown is in process, is like this. We have zoning of governorates according to 2 epidemiological levels. Second, the regional provincial crisis management committee under Wali and government is monitoring and assessing the process according to previously established indicator and based on a weekly assessment. And the committee have to identify restrictions to be lifted in each governorate and province and region. So the main indicators chosen are the reproduction rate as the spread of the virus indicator. So anytime this rate have to be under 1, and there is other indicators, for example, prevalence of active cases that must be under 10 by 100,000 inhabitants, and the occupancy rate of COVID-19 intensive care reserved bed, and occupancy rate of COVID-19 care reserved bed that must be under 65%, and the proportion of contacts tracing and followed that must be more than 90%. So I want to mention that certain obligatory measures have to.
Dr. Mohammed, you have 1 minute, please, if you don't mind.
This is the last one.
Yeah.
The last one. First, to keep in physical distancing, 1 meter at least. Wearing masks in public place, at workplace, markets, and public transport that remains mandatory, and frequent hand washing, water and soap and hydroalcoholic solution. So thank you for attention.
Thank you so much, Dr. Youbi, for this another impressive experience from Morocco. And unfortunately, we don't have a long time to address all the questions, but we are going to start with the ones that we have, if you don't mind. Just 1 minute. The first question: how are lessons learned from both successes and failure being documented in Oman? And how are the SOPs and guidelines building in accountability for implementation? This is for you, Dr. Saif, please.
we have produced policies and guidelines, and they have been approved by the Minister of Health and many of them by the Supreme Committee. And also now we started documenting the experience. We have the media cell, and now they are documenting most of the things that have been done, but there is now a guidance from the minister and like an order that we should start documenting the experience with the positives and the negatives. I mean, we learned a lot ourselves, and I think we should use it as an opportunity to improve in the future.
Thank you so much. Another question, I don't know, is Mark here with us? Mark?
I am here.
Okay, thank you. They would like to know if there is any country which assists the containment measures implemented during this pandemic.
I think most countries will actually be determining their containment measures in one form or another. There's been no widespread comparison between different countries. For example, in the UK, we've been actually on a daily basis running significant models through various groups based on what we've already done, and more importantly, the lockdown easing measures to try and establish where there would be issues and therefore put in mitigation to see whether those issues are prevented. But it's an ongoing process. I think many people have not necessarily had the opportunity to look at what we've done yet in a way that would actually help us. And that's probably remiss, but I think that's because many of us, and the UK significantly, has been very much involved in dealing with near 50,000 fatalities we've had in associated cases. Over.
Thank you so much.
If I may add something.
Yeah, sure. Go ahead, please.
Yes, for us in Africa CC, we have our knowledge management team, which they are tracking the social distancing measures that the countries are taking, and also using the mobility indicators that Google are producing, and try to compare between this social distance measure mobility indicator from Google with epidemic curve for each country. But this is still work in progress to see the impact of these measures. Over.
Another question for you, Dr. Wissam. Everybody is talking about the low number of deaths in Africa. Do you have any explanation, or it is just probably the stage of the pandemic and probably this is going to exacerbate later on? What do you think?
It's a combination of different factors. This always people asking us the same question about why low number of cases, low number of deaths reported in Africa. So our belief this is a combination of different factors. First one, the stage of the epidemic. It came late to Africa. First reported cases in Africa mid of February. So we still seeing this is the starting of the outbreak in Africa. And also because the epidemic came late in Africa, this gave us as Africa CC and member state opportunity to be well prepared to face this epidemic. This is in addition to the travel restrictions measures that the countries has taken since the beginning of the outbreak, and also early social distancing measure and lockdown measures that the country is taking. And also another factor that may explain also why the number are low, still the number of testing in many of the countries are low, and this is why we as Africa CC try to push this agenda in the continent. So it's a combination of different factors. Over to you.
Thank you, Wissam. Are there any recent international travel recommendations that have been developed by now?
I'm not sure there's actually any widespread international travel regulations, but many countries are determining their own travel policies. For example, in the United Kingdom, as of last week, and I was just responding to somebody, but as of last week, there is a 14-day isolation period anticipated when you arrive in the UK. There are exceptions to that, which are clearly laid out on .gov.uk, but that's something that's being put in place. That's going to be reviewed on a 3-year basis. And we are in PHE collating information internationally from contacts, from WHO and from open source to try and actually bring some ranking to bear on countries which are at the highest or least risk. So we can actually perhaps not have a blanket 4-day isolation on arrival for all countries when quite clearly some countries don't have the same problem as others. Over. Hello? It all seems to have gone very quiet.
I think we lost Dr. Faris.
Okay.
If I might speak about Oman, for example, now we are making our recommendations.
Sorry.
Yes, Dr. Faris.
I'm sorry. Sorry for that. I have some internet problem from my side. Apologies. A question from Jordan. How do you see the value of pulse approach? That's alternative periods of going to work, schools, and periods of quarantine. I think many countries in the region had used that. What do you think about it from your perspective? Dr. Yubi, did you experience this approach, the pulse approach?
Excuse me, the question was about
what we call the pulsed approach. That's alternative periods, a period of going to work and the school, then a quarantine, then and so on. It's alternating between quarantine and release, between restrictions and relieving the restrictions. What do you think?
We are at the beginning of this process. But if it's the question, we are processing with a gradual approach, and we start with we allow provinces regarding the epidemiological situation, regarding the established indicators, and other governorates and the regions will come back after. Based on the weekly evaluation by local committee. So I am answering also to one question that I see in the question and response link. And also for the models, there is a question about models. The models used in Morocco. We have at least 3 models, one developed by the University of Science of Casablanca, that they have very complicated mathematical models, and one model developed by a private bureau d'études, study company of specialized on these models, and one for our team. And at all time, the 3 models give us the same, approximately the same projection.
Dr. Saif, do you have any comment on that?
For the
pulse approach?
Yeah, for us, we didn't try it, basically because here with COVID-19, you can see the interfacing between science and politics, society, social, economy, security. So it's really very difficult. Yes, we are flexible with lockdown and we can go back and lock down, but it's very difficult. It's not that easy. It's easy said than done. But we are lucky because it's summer, so schooling is not going to start before September. But no, we didn't start it because practicality is very difficult.
Thank you. Thank you. Another question from Dr. Azzeddin. Not all countries that started easing off restrictions have considered the recommended conditions like the control of the outbreak, and some countries started lifting restrictions even with relatively high persisting community transmission. So what are the risks for a second wave occurrence in this case? What do you think, Mark?
I think inevitably there is that potential risk. But I think this becomes a very political, as Dr. Saif has mentioned, there's a very significant political dimension to all of this, where lockdown has occurred, people have not been able to work, businesses have gone into receivership and closed down. And we have to start weighing up against what are the benefits of the lockdown weighed up against the storing up of mental health, education related, physical violence within relationship issues that we've seen. And I know that many countries around the world have seen increases in all of these. And I think the long-lasting legacy of a shutdown will be with us for many years. Against that is obviously the likelihood of a second wave. If in releasing from lockdown, people can be advised and assured that by following social distancing, they can minimize those risks, then I think there are great opportunities. But I think, as one of your questioners asks, is what is the perception of people's and people's view on maintaining social distancing, hand washing? And I think in many places now that lockdown has been going on for quite a while, people are now not following it quite as closely. And that might explain, as one of your other questions, why we are seeing the R0 increasing in some areas, because people are not complying with the messages that are being given out by governments. And that reflects on the pulsing. It's difficult to communicate one message to a whole population to say, actually, for this 2 weeks, we're going to school, we're going to work. For the next 2 weeks, we're not. If you keep changing the message, people are going to get very confused and they'll not know quite what they should be adhering to. Over.
Thank you, Mark. It's not only the confusion, indeed, it is also sometimes the fatigue of the restriction methods and people working on that. I think this is also something that need to be addressed.
Absolutely.
Yeah.
Also, Dr. Faris, this may be a dangerous game to play. If you have some social distancing measure like night curfew, for example, and the other closure of school. And although you have some of these social distancing measures, you have noticed that you still have increase in number of cases reported on a weekly basis, and the same increase in number of deaths, in addition to increase the positivity rate for testing. Then you start easing some social distancing measures, So how do you expect that you will control the outbreak, especially if this number of cases already overwhelming your healthcare system? So with this easing measure, you will have more cases, more death, healthcare system may collapse. And this is very dangerous. We need to be very careful when we start easing lockdown measures.
Exactly. Some people, they are asking about a second wave. And there is some lack of consistency about the definition of the second wave. When Iran reported that they say they had a second wave, people in WHO said that no, this is not this is just a continuation of the first wave. And the second wave will come later when almost all the globe had some sort of settlement in the first wave. Most probably, we are going to have a second wave. What do you think, Dr. Saif, about this issue?
I think it's still a fake situation. Most of the countries are still going through the first wave, if we call them first wave or second wave. We have really been deceived by the epidemic curve, and when we are going to reach the peak or flattening the curve. The main thing was really to implement preventive measures. And even now with easing up, now we have plenty of evidence and we are learning across along the time where lockdown itself, and we need to be clear about this, it helps us to prepare our health system. If we don't prepare, if we can't expand our health system, then what for we employ lockdown? If we can't improve our economy, I mean, if our economy is not there, when the COVID came up, in Oman, we have big trouble. We have built our budget for $62 for the national budget. And now the oil prices went down to $20, where it's not even cost effective to produce oil. And therefore, if you don't have economy, you'll not be able to maintain health. And therefore, for us, the main thing we are trying to do is to improve our medical capacity to cope with more cases. Yes, we still have more cases coming up. So we are not over yet the first wave. If there's something called the first wave, we don't know what's coming up in most of the countries. So I always say that maybe we have been deceived by the peak of the curve and then coming down, and then we have a second wave. We need, I mean, it's, as they say, it's the braving the wilderness. We don't know where are we heading.
Totally agree. Really, we have to depend on our social context, political context, and economic context of the country. And meanwhile, you are looking carefully about the data and developing realistic data and correct data in order to build your next step. Otherwise, we will be, as you mentioned, we will be deceived by a lot of fancy graphs and fancy models and so on, which are sometimes not really have implication on the ground. So sorry for the, we cannot address the rest of the questions. Thank you so much, all the audience, and thanks to our distinguished guests, Dr. Mark, Dr. Said, Dr. Wissam, and Dr. Mohammed Yubi for these excellent presentation and responses. And I think it was an important webinar to highlight the issue of that indicators and for releasing and relieving the restrictions, and then to monitor after that how things are going on. Thank you so much again, and thanks to all the colleagues and to all the colleagues who are working behind the scene from GHD EMPHNET for their great job, and hopefully we are going to see all of you in the coming webinar, inshallah. Assalamu alaikum. Bye-bye.
Thank you very much indeed. Bye-bye.
Bye-bye.
Thank you so much.
Bye.